Good evening, ladies and gentlemen. My name is Jency from Star Events team, and I'm glad to be your host for our session this evening. Firstly, thank you for joining us today for our Health and Nutrition on Web online seminar in conjunction with International Women's Day today on the topic, Seek Treatment Early, There is Hope. This 1-hour session is organized by the Star Media Group with our official partner, Zuellig Pharma. It is streamed live on Zoom and on our Starbiz and Star Facebook pages. So thank you to everyone who's tuning in right now. Do share our Facebook Live link with any of your colleagues, friends or family who may be keen to join us this evening. All right, a few quick housekeeping reminders before we begin. As everyone dials into the webinar from different internet bandwidths, you may or you may not experience minor technical glitches. If you do, please do bear with us. To minimize interruptions, all participants are muted and your video cams have been turned off by default, but do interact by posting your questions. You may send in your questions to our speakers at any time during the session. If you're joining us via Zoom, click on the Q&A button at the bottom of your screen and post your questions there. Or place it in the comments section if you're tuning in via Facebook Live. There will also be a short survey at the end of the webinar, so to those joining us on Zoom, please take a few minutes to complete this survey. Your feedback will help us curate more events to suit your likes and needs. Lastly, and most importantly, please engage, learn, and enjoy. Breast cancer awareness in Malaysia is still low, and in conjunction with International Women's Day today, let us remember the countless women in Malaysia that have stepped forward to tell their courageous battles with breast cancer, surviving the disease and moving on to living fulfilling lives. Despite these stories, advancement in medical treatments and numerous awareness campaigns, many are still turning up at an advanced stage of breast cancer, which is resulting in poorer prognosis. Welcome again to our webinar today, titled Seek Treatment Early, There's Hope, where we'll take the next hour or so to understand more about cancer and ways to better manage the condition. We have the pleasure of having 4 great speakers with us this evening who are experts in the field. I'd like to firstly welcome and introduce Dr. Jennifer Leong. Dr. Jennifer is a clinical oncologist practicing in Sunway Medical Center since 2020. She obtained her Bachelor in Medicine and Surgery from International Medical University Kuala Lumpur in 2005, followed by a master's degree in clinical oncology from in 2015. She provides patients diagnosed with cancer advice on suitable oncological treatment based on the disease profile and suitability of patients to undergo the respective treatment. She is also a working committee member for the latest update in the National Breast Cancer Clinical Practice Guideline and participates actively in oncology clinical trials. Thanks for joining us today, Dr. Jennifer, and welcome.
Thank you.
Welcome. Also with us today is Professor Dr. Noor Aisha Muhammad Taib. Prof. Aisha is a senior consultant breast surgeon and professor of the Department of Surgery at University Malaya since 2012. She obtained an MBBS from in 1995 and got her MRCS ed in 2000. Following that, Prof. Aisha obtained her master's in surgery from in 2001 and Doctor of Medicine from in 2012. Since 2019, she has been the head of the Cancer Research Institute. She is also a member of the National Committee for Breast and Endocrine Surgery Specialist Evaluation, Malaysia Medical Council. She's the chairperson and founding member of the breast chapter of the College of Surgeons of Malaysia. This was from 2015 to 2018. She is a fellow of the Malaysian Academy of Medicine since 2016 and past honorary treasurer and council member of the College of Surgeons of Malaysia. She is currently a council member of Breast Surgery International. Good to have you with us, Prof. Joining us today too is Maheshwari Jagannathan. Maheshwari is a manager for the Breast Cancer Patient Navigation Program at Cancer Research Malaysia. In 2020, she was awarded as one of the first 20 exceptional leaders from across Malaysia who dared to embrace the difficult journey of social change. She has 21 years of experience in the nursing field and is a member of the Nursing and Midwife Board of Malaysia. Her specialty is in patient navigations, needs assessment, lymphedema therapy, oncology care, palliative, and end-of-life care nursing. Right after completing her service in King Salman Armed Forces Hospital, Tabuk, Kingdom of Saudi Arabia for almost 5 years, she joined Cancer Research Malaysia in 2011. Welcome, Maheshwari, and good to have you with us. And to moderate the fireside chat this evening, we have Associate Professor Dr. Nirmala Bhupati. Prof. Nirmala is an Associate Professor of Epidemiology in the Department of Social and Preventive Medicine, Faculty of Medicine, University Malaya, and practices as a public health physician in University Malaya Medical Center. She has been a visiting scholar at Queen's University Belfast, United Kingdom since 2014. Prof. Nirmala graduated as a medical doctor from Malaysia in 2001. Following completion of her master's degree in public health with distinction in 2008, she was awarded a fellowship by the European Commission, under which she completed a master's degree in clinical epidemiology with distinction, followed by a PhD in cancer epidemiology from University of Utrecht, Netherlands in 2011. Welcome, Prof. As you can tell, we have a great group of speakers this evening. Welcome to all our speakers. We hope you will enjoy the next hour of this discussion, and a reminder again to post your questions for our speakers. We'll try our best to answer as many questions as possible during the Q&A session later this evening at 8:45. Prof. Nirmala, over to you.
Thanks, Jency. A very good evening, everyone. Today, as we celebrate the International Women's Day, I'm so honored to moderate this session focusing on breast cancer. And specifically as our topic, which is seek treatment early, there's hope, is tied so closely to gender inequalities. It is only natural that we should be also focusing our conversation, if not everything, but at least partly of our conversation on closing the gender gap to close the cancer gap. So breast cancer remains as the most common cancer among women worldwide, but this is also the same in Malaysia. And early detection of breast cancer is absolutely crucial, and it greatly impacts the cancer outcomes, both in terms of survival and how well women live following diagnosis. But the problem is that early detection remains as one of the biggest challenges in the low and middle income countries. And central to this discussion is that a great proportion of Malaysian women continue to be diagnosed at advanced cancer stages when it comes to breast cancer. So that is to lay the story, to paint the picture of where we are right now. And back to today's session, I think I would like to start with Prof. Aisha as the breast surgeon. Aisha, can you share your experience on the issues of why women are diagnosed at late cancer stages in Malaysia?
Yeah, I think this is a very hot topic. And unfortunately, with the COVID-19 pandemic, I think we will be seeing a more rising trend of stage 3 and 4 breast cancer, unfortunately, because of the delays in people presenting to the hospital, as well as the fears of having to go to the hospital because the health system is focusing more on the COVID-19 pandemic itself. So the most important thing that we must know about advanced presentation is that our literacy rates on breast health is actually quite dismal. So a study, an in-depth study of 20 women that was done quite some time ago has shown that actually it's not just patient aspects, patient factors that delay the diagnosis, but also health system aspects. So the patient delays are usually due to health literacy issues. So for example, a lot of women do not know as they age, their risk of cancer actually increases. And of course, symptoms of breast cancer, and the most common one is the painless breast lump, is commonly missed by a lot of women because they didn't think that a painless lump could actually be a cancer. So the usual patient we see in clinic is someone who has a lump and they are well, they're able to go to work, they're able to function normally. However, because of that, a lot of women are a bit fooled by that fact and hence did not present early. And also the information on screening, I think is very patchy out there. A lot of people are doing tumor markers and other non-effective screening methods to detect cancer. So I have to say the other issue, of course, from Nirmala is finances. Resources are limited, I think, especially now. And even back when I did the study, financing of treatments and diagnosis was a major issue. So women being, we always talk about the gender bias. Women, when they make decisions, sometimes affect their outcomes too. Some women have difficulty even coming to the hospital when they think they have cancer. And this is because they could not cope with the scariness, a lot of patients will tell me the fear is something like fear of ghosts. You cannot explain it, you cannot control it. So having the ability to cope when you are faced by this threat of maybe having a cancer is something very crucial for women to have, to be able to find that support to go forward and seek that diagnosis and that treatment. In the health system aspects, we have done a survey of 6 public hospitals. We found that there are a lot of issues even in the health system, in that a lot of sometimes even symptom recognition by healthcare providers are also problematic, as well as the diagnostic process itself. So having a diagnosis of cancer is a bit, you need a lot of people to do it. So you need radiologists, you also need the pathologists, and you need a very strong, cohesive sort of communication between these departments to actually produce that diagnosis within the stipulated time. And now we know it's about 60 days from the time you have your symptoms. You must get your diagnosis resolved within 60 days. And that is a global KPI put up by the WHO. So I think from Nirmala, the issue may be complex, but because we can actually make a framework out of it and try and solve different issues. So I think one of the things people always talk about are the social, cultural
Aisha,
taboos.
can I stop you for a while? Because there are a lot of nice information that you have shared with us.
Yes.
And
yes.
On one side, you are saying that, when we look at late stage diagnosis, it's not just the women alone, but it's also the health systems. So they are actually, if you broadly divide it, it can be divided into both sides, yeah? And when it comes to women, you think literacy is an issue, and then gender inequality and social inequalities, and the COVID pandemic has seemed to exacerbate whatever problems that we have at hand. And on the other side, the health systems are also struggling to keep up with the care for the other diseases and so on. So going to the health system, so you say that patients are fearful, and do you mean that they get lost or overwhelmed from the point of diagnosis? Is it the diagnosis, or is it the post-diagnosis? So I think that a few issues here. So with that, I think maybe we can ask Mahes, with your experience of viewing patients and working with them very closely, can you share some insights? What are the struggles of women when not only when they have symptoms, but also post-diagnosis?
Right. Actually, as a Malaysian, right, for us, we are very lucky that we have universal health coverage. We have services that is available in private hospitals. So me and my team, we work closely with women who are seeking treatment at the state referral hospital. So what we observe from them, right, there's still a lot of, they still have lack of awareness, what kind of facilities or services that is available. That makes them to take a longer time to come to the right resources at the right time. So even when they come into a healthcare system, right, healthcare system is very complex. Even for healthcare professional like us, we have to navigate through. So they constantly may need a navigation system that can actually tell them what to do next and what is to be anticipated next. So another part that we see most is sometimes women that comes to the healthcare system, right? Now, a newly diagnosed breast cancer patient has already received this unfortunate news to say that it's confirmed cancer. But they also now has to face something that back at home, the reality at home. Sometimes they are very hesitant, like how Prof. Aisha is telling that, you have financial problem, transport. They're not sure whether by them telling this to the healthcare professional, are we supposed to tell them? These are the people who are supposed to solve this problem to us. So the hesitance is always there. And that makes it more longer time, or sometimes it's more difficult for us to solve their problem. That's where sometimes they may get lost in the system, because they themselves not sure whose role is that to solve my problem in that system. And especially for somebody who just newly diagnosed, to navigate the entire healthcare system is too complex, while they just trying to think about what is cancer, what may happen to me before surgery, after surgery, what are the side effects. So it's just too much. It's an overwhelming situation, and they definitely need navigation throughout the healthcare system.
So they need some hand holding and have someone to call, to speak to. And I know, Mahis, that you have been working very closely with women from the low income group. But I think from my perspective and what we have done with women from all walks of life, from different backgrounds, professionals, homemakers, we know that women, despite all this socioeconomic background differences, they all have issues. So when we talk about disparities and we talk about women left out, it's not only those who are from the low income households, but also from those from the high income households, the professional women, because of these conflicting roles as a mother, and then as a breadwinner, as a wife, as a daughter, as many other roles. So what do you think, how do you think, like, based on your experience, can you, expand a bit more on maybe women from low income, but we know that the high income women also have the same issues?
So what women see in the healthcare system, right? So what to expect, the anticipation of them coming into the healthcare system. Sometimes it is even starting at the primary care clinic. You've been in let's say you are in a taman, and let's say you're in Klang Valley, right? What is the nearest clinic kesihatan that you can actually go in and get the information from the doctor? Or let's say, where shall I turn up to? The way that you go into the healthcare system, not many people will know about it. So when you come into an entry where you can be referred to a system, that is where patients sometimes just don't know where to go in. So sometimes they might get lost and try to navigate themselves, maybe go to a GP, maybe go to a medical center, then they come around and it becomes more delayed. And sometimes these delays are just them trying to sort out what is best to them. And due to this delay, and that will actually make them to have more difficult decision to make at a time with the clinical team. That puts them in a more difficult situation sometimes.
Okay, thanks for that, Mahis. That's very insightful. And now going back to early detection, right? We heard some words just now about screening, and so we know that screening refers to women who feel good, who feel well, trying to see whether going and undergoing some tests to see whether they have breast cancer, early breast cancer or not. And often we hear about mammography, clinical breast examination, but we're also increasingly seeing women undergoing screening tests, like blood tests for tumor markers, for instance, all in the hope of getting their breast cancers detected early. These tests sometimes are often offered to them as part of a health screening package, or sometimes just recommended by friends, by family. So I'm going to ask Dr. Jennifer. Jennifer, what do you think about tumor markers? Is it something that, does it have a role in early detection of breast cancer? Can you share with us?
Hi, thanks, Nirmala, for the question. So I often get asked as well, patient or individual who booked an appointment with my clinic, and then they have got raised tumor markers because it's so readily available. Like you say, it comes in a package, like you have the CA, CA199 and CA125. So essentially tumor markers are blood tests that are done, and if it's raised or if the value is high, it can give a red flag. And that's when that individual would then pursue further tests, such as a mammogram or colonoscopy. But the thing is, tumor markers are not well validated as a screening tool, which means it has been tested over many trials and it is not consistent, i.e. if the result is normal, and this is where we want to get a message across tonight, that what we are worried that if the tumor markers come back as normal or within the normal limits, a lot of individuals have a false reassurance that, I do not have cancer. But that's not true, because cancers in the very early stage, sometimes there's no raised tumor markers. But when the tumor markers are high, then it can also give anxiety if after further testing or scans, and sometimes the result comes back as negative. So the thing is, the best well-validated tool right now that we know, screening tool, is still mammogram for breast cancer. However, tumor markers do have a role in clinics, in that if it's high, we use it to monitor the response to treatment. So if a patient who presents with very high tumor markers and it goes down as you go on to do their treatment, then you know that they are responding to the treatment well. Same, you can use it to monitor for recurrence. So there's a role of tumor markers, but at this point of time, not as a screening tool for cancer.
Okay, that's very well and clear. Thanks, Jennifer. So I think we would like to speak more about treatment. So we spoke about detection, and so we know that surgery is the mainstay of treatment for breast cancer. Is it always the first option for a vast majority of women? That I have to ask Aisha. So Aisha, can you give some insights?
Yeah, you see, treatment of breast cancer is multimodal. So it cannot be just one treatment. So some people may need 2 treatments, some people may need 3, some people need 5. And it goes across the range of surgery, radiotherapy, chemotherapy, targeted therapies, hormonal therapy. So some people need 2, some people need 3, some people need 5. So traditionally, surgery was always the first treatment. But however, this is no longer true, because there have been a lot of progress in understanding diseases, the subtypes of cancer, and we know certain treatments require the patient to actually have chemotherapy and targeted therapy first, so that that patient will benefit from the whole treatments. Because this type of patients, we may need to do what we call neoadjuvant treatments. Neo meaning before surgery, adjuvant means additional treatments. So neoadjuvant treatments that require some sort of chemo and targeted therapy sometimes, or even hormonal therapy sometimes, then they go for surgery. The information from that surgery will tell the doctors whether this patient will need further treatments. So if we operate on the patients first, we have lost this information, and that patient is no longer going to be able to have additional treatments after already, having the surgery at the upfront. The other thing we must know about is that it is always important to know the stage of the cancer, because if the cancer has already progressed and has spread beyond the breast and the lymph nodes in the armpit, so that means it can go to the lungs, the liver, and at this point, surgery may not even be an important treatment for that patient, because we are actually trying to control the disease and maintaining good quality of life. The studies have shown that people who have been operated upon, when they have metastatic breast cancer, they may actually have lower quality of life, and there's no additional benefit in terms of their survival rates. So I think surgery now has become like, usually what happens in the diagnostic pathway, as what Mahes mentioned, it is complex, but who you should see after seeing your first doctor is the surgeon that makes the diagnosis. And that surgeon, being the first person you see, must be updated and must have connections with their oncologist through multidisciplinary team meetings, so that they can recognize who to refer first for this chemotherapy or targeted therapies first. So surgery, and I'm afraid at the moment, is not the first treatments that we should think about, especially those with what we call the HER2 overexpressed cancers, as well as the triple negative breast cancer. So I think there was a question about the subtypes.
Yeah.
Maybe later, I think Jennifer can talk more about that. Yeah.
Indeed. Thanks, Aisha. I think that was a very nice, quick overview. And you brought out the point that surgery, yes, it's still first option for a vast majority of cancers. But we also know that for advanced breast cancer, surgery may have less role, because we know from evidence that for these women, maybe something else should be done. So because we have a substantial number or proportion of Malaysian women who are diagnosed with advanced cancer stage, what about them? Is there hope? So I think for a long time, we have been painted, the narrative, the picture has been always very sad, very gloomy. We said early detection is good, it's fantastic, please come early. But what about women who are diagnosed late? So what is the current scenario? So we know from the global scenario, also from the Malaysian scenario, even women who are diagnosed at advanced cancer stages, we see that they are living longer, living better now. So this is something that we have seen in Malaysia, in our own Malaysian breast cancer population, and also worldwide. So that brings me to that. So we have hope. There is hope, right? So
and hope that we should mention, Mala, before I forget, is the breast conserving surgery. Because people must know that the patient may not need a mastectomy. I think that is a major issue also that they need to know about.
Good point. So they need not lose their breast. I think when we're talking about surgery, women are very wary that they will lose their breast, but we also have breast conserving surgery when only the lump is removed, followed by certain number of therapies, and to make sure that they still can keep their breast. I think that's the easiest way to say it, right? And then going back to these women with advanced cancer stages, so there is this inherent, like when we talk about chemo and, this fear of ghosts that Aisha mentioned earlier, I think that fear of ghosts is about, facing a very hard, life-changing diagnosis. I wouldn't use the word deadly disease anymore, because it's no more deadly, but it's a life-changing diagnosis. And so we also talk about chemo, right? So do all women with late-stage disease need chemo? Can some patients do away with chemo? Do they have other options? Jennifer, over to you.
Thank you. I have to thank Prof. Aisha, because she did do a very fantastic job when it comes to the neoadjuvant part. So yeah, we know that selected group of patients, especially the triple neg and the HER2 amplified, will require some form of systemic treatment, i.e. either chemotherapy or immunotherapy, before we go for surgery. But over here, we also want to focus on a group of women who cannot undergo surgery, or, in stage very advanced or stage 4 disease. So over here, we would like to say that having a stage 4 breast cancer is not a death sentence. And that's a take-home message for all the viewers out there. So a lot of women are afraid because apart from having to cope with the cancer diagnosis, the next question is, do I need chemotherapy? So that is also the question that is always posed to me in the clinic. So depending on the molecular subtype, so in short, breast cancer has got, you have to know what is the molecular imprint or signature. We call it the molecular signature in the patient. So essentially, there could be an estrogen receptor producing tumor, progesterone receptor, or HER2. So for someone who has got an estrogen receptor positive disease and HER2 negative disease, there are actually new treatment landscape. And we have shied away from trying to use chemotherapy unless we feel that the patient is going into organ failure. And a lot of time we're talking about someone who has got breast cancer that has spread rapidly to the liver, and you have not much time frame left. And that's when we actually use chemotherapy, because it offers a very quick control of symptoms. Apart from that, we're trying to shy away from using chemo. And nowadays, there are new targeted therapy that is known as CDK4/6 inhibitor. So these are very convenient oral drugs that are taken in combination with the hormone tablet. So that's why they have to be estrogen receptor positive disease. So that's where you can have this discussion with your doctor, explore this option with them. And I have personally treated patients with this treatment. And the beautiful part is, besides being able to provide survival benefit, meaning patients are able to live longer and also live longer with a good symptom-free lifestyle, they are also able to go back to work. as we know that when patients undergo something as as intensive as chemo, a lot of them will have to take time off work. So there are a lot of indirect factors, like they lose their income, right? Or they lose their household income, and that impacts the family. It doesn't just affect, so having a cancer diagnosis doesn't just affect a patient, it affects the whole family. So with this treatment, if it's possible for a woman, then they're actually able to go back to work, able to have a lifestyle and able to resume whatever lifestyle that they have before. And a lot of them do have young children, and this allows them to still spend quality time with their family members.
Okay, great. That's a very nice, very positive, news that we are sharing with everyone today. And going back to chemotherapy, so we know that there are other options beside chemotherapy. There are targeted therapies, there are hormone therapies, and some of them are oral, therefore they can be taken at home and so on. But going back to chemotherapy, there are some women who need chemotherapy, and some women are so fearful. They just look at life in a very different way the moment the doctor say you need chemotherapy, but that's not always true. So of course, chemotherapy is associated with side effects, but we know from our own work that whatever side effects and difficulties that they go through is transient, meaning that it gets better and eventually, they lose hair and everything, but life goes back to normal, your quality of life comes back. So what is available for women who have to undergo chemotherapy? Is there something that we can do to make them go through and make the whole process livable and they can enjoy life eventually? What else can be done, Jennifer?
I think a lot of time is also the perception of fear, because a lot of us would have known, a family members, a friend, a colleague who's undergoing chemotherapy or diagnosed with cancer. So that whole journey of watching them, having to go through chemo and all its side effects will have a profound psychological impact on ourselves. So especially in the early stage, I do have a lot of women who ask me, simply, I have got my breast tumor removed, and then I have got clear, my scan, my PET scan, my CT scan showed that there is no disease left. Why you are advising me to go for chemo? So as hard as it is sometimes to explain, we do look and stratify as a doctor who treats cancer patient. We actually want to stratify what is their high risk features. So there are some women, for example, those with HER2 positive disease or triple negative disease. We know from data, from many, many years of follow-up, that these are the group of women we have to watch carefully because they have higher risk of recurrence. And so the chemotherapy is aimed to actually to reduce this risk of recurrence. So I think it's important for us to now make the patient, the women, participate in the decision making. It's no longer in the past where it's very patriarchal. So, as a doctor, I say you have to do the chemo and you follow it and you have no idea why. So nowadays, and you bring the patient into the decision making and also involve their family members, like their spouse. So there's a support system there. They tend to understand the rationale of the chemotherapy better. So I find that in this group of patients, the compliance to completing or even agreeing to do the chemotherapy is higher. So besides, just offering patient chemo, we also have to offer them a supportive treatment. This is so important. So meaning that you actually offer patient a lot of medication to help suppress vomiting. Because one of the most common side effects with chemo that are fearful in many of us is that the nausea and vomiting is going to make me lose appetite to eat. And if I lose appetite to eat, I'm not going to have any immunity left. So that is something that we can do. There are so many medication out there that is much better these days compared to say 10 years ago. And we also sometimes give women the booster injection to make sure that their white cell count does not crash during chemo, i.e. there is a less chance of them having to be admitted because they have low blood count and infection. So all in, the supportive treatment on top of the chemotherapy will make the journey more pleasant.
Okay, thanks, Jennifer. That's very, very comprehensive, and it adds more. It's more convincing. Like you have therapies. These therapies can make your quality of life dip a bit, but they're also solutions. So that just speak to your doctor. I think that's one of the main message. voice your concerns to your doctors, right? And I'm going to pick on that supportive care. So we know we have medical supportive care, but we also need that social support, that tender loving care. And I think for that, the family, the community can also play a role. So I want to ask Mahesh to share how family support plays an important role, all the other kind of support, social support, how it can impact patients' well-being, not only from the perspectives of chemotherapy, but on the whole throughout the treatment. Can you share, Mahesh?
Yes. So our patient, right? I think family support is very, very important, as equal as having the right clinical team to treat. So it's like a partnership, the doctors and also the family support. So a lot of families that we have worked were very, very supportive of the patients. So the information, education, and everything is to be given to the family members when the women are not ready, or sometimes it's too overwhelming for them to digest all this new information. And part of that, another part of that is women that we know are like pillars in the family. So when they get the the news of the cancer, sometimes it's too overwhelming, and they need to there should be transition of role in the family. Somebody else has to take up her role, and somebody else has to let her to help her to stabilize things at home, so she can actually focus at home, so that she can go for and attend those treatment and attend all these appointments with the doctors and everything. They should be like taken over of this heavy lifting that she was doing at home, so that she she will have more clearer and more focused. So she's not worried about what's happening at home while she's supposed to go for surgery. She's not supposed to have all these things in her running at the back of her mind, but it's more clearer. And part of that family support, from the family support itself, the family supports are the one who will be able to give them financial support. Over these 2 years, pandemic has really hit hard, and many family has actually lost a lot of income. So sometimes we have to come together, pool resources, and also help this patient to actually have those treatment. And the second one is also logistic. There's going to be a lot of appointments attending, bringing them to come for chemotherapy, going for radiotherapy, sitting down with the doctor to understand what can she has after chemotherapy or radiotherapy. There's a lot of things that family supports are very important. And the most important part is also the emotional support. As human, right? When you have been announced to have a life-limiting illnesses, it's not easy. It's not easy. So to have that emotional stability will help women to overcome those negative thoughts that it's keep on coming. So family support is like the other side of the partner. It's like in this care, patient is in the center. The family support is the one that is going to bring them very, going through all this treatment. And then the healthcare system, the healthcare professional are the other side of the partnership, where they bring her towards completing the clinical pathway of her treatment. So it's a partnership. So family support plays a very big role. And we have seen many patients able to complete treatment despite of many challenges or many hiccups, because they have a very strong family support.
Okay, thanks, Mahesh. That was very insightful. So I'm going to ask you again. So you were talking about family and how it's so important because they serve as, and they need to take over because of these multiple roles that women play. Whether they are poor, they are rich, they are working, they are not working, they have to have someone to, take over the fort while they go and get their illness and their cancer management sorted. So going back to what you said, right? How can we include the patient, the core of the conversation? How to level the playing field to close the cancer gap? So I'm asking because you are the one who work day in, day out with patients, their families. So what is your take on this?
Right. I think the most important is building the trust. It's very important. If you think this is a very important journey, is the most important moment of their life, building the trust is the most important one for us, everyone, the family, the doctors, building their trust. And people has to ask what matters to them. Stop asking what's the matter with you. when you don't want to go for this treatment, you say that this is not something that you believe and everything, ask what matters. Because if you start asking those questions, right, they can be women who are very vocal. They have all these means, the resources, the capability to ask what they need and what is their priority. But they can be also women who are not doing this. So we have to ask them what you want and make sure that they are part of the entire conversation during decision making, shared decision making. It's not supposed to be done by a family and these women will just go for the treatment. Somebody who's going through the treatment should be part of that decision making. While they are in the part of the decision making, this is where they can actually ask all the questions, clear all the doubt, it's like a safe space that the doctors, the family are there to ask those questions for the family, because we are doing a very, very important decision for these women. So the trust is really, really important for these women, so that, right after that decision, there's an anticipation what to be expected the next. So then the family thinks, the women thinks they are the center of everybody's attention. And I'm given this opportunity to make the decision which is valuable to me. If a woman think that this decision, which is not part of whatever that I think is relevant to me, soon or later, when the value and belief is not aligned to whatever that is happening to her, this is where the patient may go defaulting, or maybe there will be disruption during the treatment. This is where you lose the patient. So in the navigation team, right, we work with them from day one. It's not when they're only trying to tell us that I don't want a treatment. We work with them from day one. So we ask them what is their need, what is their preference, what matters to them. That's really, really important. By building the trust, that will allow the women to stay within the system, so she can actually complete the treatment, so she can survive, she can be with the family back. Most of the time when we ask those questions to women, what motivates you in this journey, almost about 95% says it's their family. So, right, so we go back and tell them, there's something that for you to look out to, and you being the pillars, and with all these supports that we're going to do, and trust the system, trust us to navigate you through this and complete the treatment together.
Okay. Thank you, Mahis. So you were talking about family support, and so we also know that from elsewhere, like for instance, in the US, besides the family, the community comes to help the women who are diagnosed with breast cancer, who have to go and get treatment, and then also, upon finishing therapies, they still need help. So we have heard of companies or startups which offer house cleaning services, like ferrying services. They actually take patients to get treatment, or childcare. So we even have university students offering to do, taking care of the children of women while they go and get therapies and attending their physiotherapies and so on. So those are things that are available elsewhere. And I think here we have some gap, so what sort of patient support group, or what about how to help patients to relate and cope? So we know we have this patient navigation, but it's not widely available. Right. So I think I want to switch gear a bit and ask from the clinician's perspective, like Jennifer, like you have been treating patients. Do you see differences in terms of those who receive some sort of a patient support group or peer support? What do you see in those patients?
That's a very good question and a very important aspect for us to cover. We know that, finishing the treatment is only half the journey, and getting the emotional support, like how Mahis put it, is so, so important. So I find that there is a gap, in that there is not much support that the women can rely on. So the network like National Cancer Society Malaysia, Breast Cancer Network Support Group. So even sometimes my patient sits outside the clinic and they speak to another patient, they're undergoing the same journey, like both are breast cancer survivor. Already when they walked in my clinic, they're already all smile. Because a patient can relate better when they have another patient, supporting them. It's a different kind of moral support they get apart from the clinician and family members. So I do urge, all the breast cancer survivor out there, if you could find a friend, or we, get in touch with some support group like NCSM, and then they will actually link you up to this group of survivor, and they can actually boost the morale as well. And they feel that they are not alone in this. So as much as family members and trying to give their support, it feels slightly different as of, someone that comes that are doing the same treatment with them. So I find that really matters a lot.
Thanks, Jennifer. Even the work that we have done with a lot of patients, not only breast cancer patients, but patients with various other cancers, we see that, coping, one of the things they talk about coping is they want someone to speak to. And sometimes maybe the healthcare professionals are a bit busy. They can speak to them, but also speaking to people from their own group helps. But also some people have unhealthy or unhelpful coping mechanisms. And Aisha, can you share your experiences on what sort of things should not be attempted, or what are things that may be detrimental to patients in terms of coping?
Yeah, I think coping, as you can see, it goes across everybody today mentioned coping. You see, the most important mental health issue that our patients face, I think from our research shows that it's actually anxiety. Anxiety, as well as the modifying factor of this anxiety, is actually social support. So I think you mentioned everything. So get your support and make sure you settle down your anxieties. And how do you do that? So first of all, I think when you go through the diagnosis, it's like a roller coaster. Suddenly your life is out of control. People are telling you to do things that are to you maybe toxic, you're losing your hair, you're going to lose your breast. So a lot of things that will put you into this high gear of roller coaster, anxiety, attacks, right? So how do we cope positively? So we must first understand that it is a natural process. And I have to say that it is, you're human, you will feel all this. It's very difficult not to feel it, but in order for you to be able to hold on to the reins, to make sure that you're able to get out of this in one piece, you have to start putting on your thinking cap. You must be a bit logical. That's why we need a friend. So I find that the first thing that I usually tell the patient is that, especially if she comes alone, especially a lot of women who comes with an abnormal mammogram or a breast lump, they bring a family member with them. But some women, they come alone. They need to be aware that they need the social support. So the next time they come, they may bring a sister, a friend. So this is important. You must get that social support. And knowing that you have to put your thinking cap on, the most important thing that you need to do is to accept. So a lot of psychological theories, on how people face life-threatening diagnosis. They go through a whole period of denial, anger, right? But what is at the end of the whole thing so that that person can move on is actually acceptance. So, the Muslims, they always say redha, right? So it is the same thing. So if you can accept that you do have cancer and you need to do something about it, and then you should be able, with social support, with your own network, get on with the next processes. So the other thing, I think Mahes mentioned that word trust. The only reason why people will go through their treatments is that trust. And I think she mentioned it wonderfully about shared decision-making, knowing what matters most to you, and you can communicate that to your doctor will help you craft what sort of treatments you need. So maybe some people may have planned a trip. Like I had a patient who had planned a trip to see her daughter graduate in the US. So why not take hormonal medication first as neoadjuvant treatment for 6 months and come back for her surgery, for curative surgery. So all that can be tailored. As long as we are doing the recommended treatments, you can actually discuss this with your doctor. So the other thing beyond trust is confidence. So how do you get that confidence? So people don't like this term, a lot of the doctors say, shopping for doctors. But actually, you're not shopping for doctors. You're just not shopping. You're just getting second opinion so that you know that treatment should be the standard treatment. And you're confident that that treatment, because you've met 2 doctors, they talk about the same things, that is the right treatment. So how do you choose your doctor? Whichever doctor that makes you feel confident, So I think these are the steps, and being today's International Women's Day, we have a lot of gender issues also. You all mentioned it about having a lot of issues. Women have to do everything, and how men play a major role sometimes as husbands, as brothers, as fathers, and how they can help. Sometimes I find that men are very supportive, but men must also be supported. You would notice that some couples, the husband is actually crying, the wife is actually strong.
Right.
Okay, and he may not be helpful, but if he is passive and he doesn't play any role in the decision making, a lot of women are lost. So I think my take home for men out there, please be active in the decision and the discussion, so that your wife or your sister or your mother or your daughter feels supported when she makes that decision. You know, men do not want to make decision of mastectomy for their wives most of the time, because they don't want to have that responsibility, but they don't realize they are so important in that decision making. You know, so I think we have a lot of things that would be better when people communicate better.
Yeah, I agree. So especially I find sometimes, you know, as a spouse, you know, or family members, they don't know what is the right word to say. You know, you don't want to say the wrong word. And so there's this silence. So I think it can start off that you can listen, you know, by providing a listening ear, because every patient has different coping mechanism. So it always starts off, like you beautifully put it, there's denial. And there's anger, a lot of questions like, why me? Why do I get this cancer? I eat so well, I exercise, but I still get, you know, cancer. So we have, as clinicians, be able to identify which part of the coping mechanism the patient is going through, and not just the patient, the whole family is coping with the disease. It's a disease that actually affects the whole family structure. So until the patient can come to an acceptance, then they are able, you can talk more about, you can progress further on the treatment part, I feel.
Yes.
Thanks, Jennifer. Thanks, Aisha. That was very nicely put. I think that's a very important message that we need people to get on. And I think the other part about this whole topic that we are talking about, gender, promoting gender equality and reducing this gender disparity, we cannot have this conversation if men are not involved. Otherwise, it'll be like shock sendiri, you know, like women get along and say all the things that we want, but there are no male partners, no men to support us. So it's all together, it's everything. And it's not just about treatment. It's even before, at the stage where women detect something is wrong with their body or suspect something is wrong with their body. Even at that time, they need their male family members, male partners to come in to give that confidence for the woman to say, it's okay, yes, life needs to go on, but you need to get well. Only when you are well, the family is well. We all know that women stay at the core of the family, right? So happy women make happy families. So, and also taking that along towards past treatment, we also know things like sexual health and, you know, returning to work. All these are issues that affect women. Often they put that aside because they put their families first. And maybe because of the disease, they think that maybe sex is no more important. So those kind of conversations need to come in, and the men need to play an active role. So I think we have to accept that, you know, all this talk is with men also in the center, right? And I see that we have lots of questions. So I think we should, you know, do some justice and also answer some of the questions that we have here today. So we have a whole long list. I can summarize some because there are a lot of overlapping questions, but let's start with one of these questions. How do I know what type of breast cancer I have? It can be either Aisha or Jennifer, whoever wants to take that question.
Yeah, I think just to say that biopsy you get to diagnose the cancer will tell us the type of cancer. So this is also an issue of health system sometimes when the biopsy is done without the biomarkers. So what do I mean by biomarkers? There are three things that we look into in the report: the estrogen receptor, progesterone receptor, and the HER2 test. So ER, PR, HER2, these three things will tell us the type of cancer, which will determine the type of treatments you need. So make sure when you go out there, if you are going to be diagnosed, make sure this test is done together with the diagnosis so that we save some time to get on with the treatments. One of the factors that affect delay in diagnosis and treatments is diagnosis in another hospital, in most of the public hospitals, because when you are diagnosed somewhere else, to get the report, it may take a few days. And then you go and see a surgeon, and the surgeon say, oh, I need the ER/PR HER2. And that person has to go back to the other lab to get that result. So that will take about 2 weeks, which is a bit long. So if you are going for a diagnosis, make sure your doctor is going to order ER/PR HER2 also.
Okay. And is screening at government hospitals free?
You see, screening should not be done wholly in a government setting. Because imagine if we do screening, what are we going to do with women with urgent symptoms? So I would say most of the states have some sort of mammogram subsidized programs. Even LPPKN, they have subsidized mammogram programs. So seek out those type of mammogram screening programs. So in Selangor, I think they have launched the CanCell, which actually provides free screening tests like mammograms, IFOBT for colorectal cancer. So please seek out those types, because that can also be done in private hospitals. They have panels. In government hospital, we have to focus on making diagnosis quickly. So we cannot be inundated by a lot of women who are well and they are just going for screening. So that's my take home. But screening in a private setting is not that expensive. I shouldn't say that, but mammogram and ultrasound probably will cost about 280, maybe in some centers 300 ringgit. The problem is the biopsy. The biopsy usually in a government setting is almost free, but in a private setting it can cost you something like 3,500 ringgit. But in the university hospital where we actually pay, we are not heavily subsidized. The cost of the biopsy may cost about 1,000 ringgit because we do the ER/PR HER2 upfront. So I would say if you have problems with biopsy, go to a government hospital for the biopsy, but the screening, do it using other subsidies that are available out there.
I think also in the Pink October month, they are usually campaign, awareness campaign. So that's when they do get a subsidized fees even in the private setting. So since we're at the topic of screening, so for women who are at average risk, meaning no strong family history of breast or ovarian cancer, screening mammogram, when should you start doing your screening? It's at 50 years old. You can repeat it every 3 years if it's normal.
I think in the Malaysian guidelines, we have it at 2 yearly at above the age of 50. But we must remember, even if you do not want to go for mammogram, let's say for screening, you can even have what we call clinical breast examination. And that has been shown, isn't it, Nirmala? I think that shows that lives are saved because women above 50 go for 2 yearly clinical breast examination.
So clinical breast examination is something that is recommended in countries where mammography is expensive. And there's a very large study in India which showed that it really saves lives, especially in women who are more than 50. And clinical breast examination means you go to a healthcare professional and that healthcare professional examines your breast, even if you do not have a lump. I think the key point here is you feel well, you're okay, but you just want to make sure that you want to see whether you want to rule out a possibility that you have breast cancer, go and get a clinical breast examination done from a healthcare professional. That means a trained nurse or a doctor. Yeah. And then I have another question. I'm pregnant. Can I still seek treatment? I think Jennifer, can you?
That's a fantastic question. So yes, even if someone is pregnant and they are diagnosed with breast cancer, there are still treatment that we can offer and still be assured that the pregnancy, can go on smoothly. So of course, in women who are pregnant, who also have breast cancer, there are certain types of surgery that we will recommend. And also we will actually be able to, if let's say the patient is high risk, we'll still be able to offer chemotherapy after the second trimester. So when the organs are fully formed in the first 8 weeks, then there are certain chemotherapies that are well studied and shown to have minimal effects on the baby. or the fetus. So it is safe, but we manage the patient together with the obstetrician, the surgeon, as well as the oncologist. So important thing is if you have a lump during pregnancy, a lot of them things maybe it's just an engorged duct, milk duct, or, after when they're breastfeeding. But if this lump doesn't go away, again, it's a concern. So please do get checked.
Okay, thanks, Jennifer. Now I've got a few questions for Mahes. I think I'm going to start with something that seems like a call for help. Because of cancer, I have suicidal thoughts. Is there someone I can reach out for help? That's one question. And another question is also along that line. Are there associations or groups who can counsel us on cancer care?
I think currently there's a few support groups that is available. And I think you can actually look out to, there's National Cancer Society Malaysia, there's a Pink Unity group that supports breast cancer. There's also Breast Cancer Welfare Association that has good support groups that you can actually access to their website. But there's also where you can actually seek out if you have those negative feelings towards suicidal thoughts, to get contact, to befriend us, that usually is out there, that you can actually you can either call them to a hotline that you can actually access to a counselor that can actually talk to you and just ask what's actually happening, what kind of situation that you're going through. Or if you think that you do not want to speak to anyone, there's an option that you can actually write through an email to the befriender as well, so that you can actually have them written rather than trying to talk and say what is happening to you. And the counsel for cancer care, most of the time in different setting, I think many of the resources from the support groups are more in the city, and it's a huge divide between the rural area and also the city area. But I think now right after pandemic, there's also option where you can actually reach out to those support system through phone, and those hotlines are available that you can actually seek out and talk to them by phone, and don't have to actually go face to face during this pandemic and worried about those infection rate at this time. So these are the two options that is available. And for, let's say you are going through cancer care and you are attached to a hospital, I think the best way is to seek out assistance from the team that is caring for you, because they will actually know what kind of treatment are you going through, and they can actually advise you where can you go for help. And those help can be available to you locally, rather than you looking out for a lot of things outside there, maybe not reachable and maybe not relevant, maybe it's too far away for you to reach out to these people.
Thanks, Mahes. I think going back to the first question, right? If you think that those are very long-winded and you really need help right now, you can also drop your email or your contact number in the chat group, or personally you can put it in a way that we can provide the organizers email group so that we can find help and link you to the right person. So I hope that the person who asked the question is there to hear. Aisha, you wanted to add?
Yeah. Maybe, if you have suicidal thoughts, it's also an emergency. You can also walk into an emergency department, because sometimes if you're depressed, you may not be able to control, this feeling. So it is okay to actually go and seek doctor, even a general practitioner. I think a lot of questions are asking about, they're all scared of going to the hospitals, right? I think, we have many doctors out there. They are primary care doctors. Usually we call them general practitioners. They run private clinics, but you also have family medicine specialists. And these are actually specialists, and they are also based in the government community clinics. So a lot of people think, you have to go to the hospital to get specialist help. But actually, even in the community clinics, there are specialists there. So if you have a problem, let's say psychologically, you just cannot accept there's some suicidal ideations, you can also go to the clinic. Just, because a lot of people don't know, there are actually family medicine specialists in our community clinics out there.
Okay. I think there's another question on where to get information from for navigation program. Is there a number to contact? Mahis, is it okay after if we can share any resources in the common platform?
Yes, we can share some of the hotlines that is available. Currently, the navigation program is only available at four government hospitals in 4 states. We can actually share that out, and if you are from that localities, definitely you can actually call us up and get some information from the team.
Okay, and there's a question, are the new treatment mentioned by Dr. Jennifer, the non-chemotherapy, available in government hospitals?
Yes, they are. It is available. But of course, when we in any kind of settings, especially in government hospital, we always talk about financial implication as well. So there are 3 available brands for this targeted therapy that I mentioned. And at the moment, as far as I'm aware, only one is available. But of course, there's a selection criteria. So yeah, so when you go over to seek the doctor's help, firstly, the doctor will do a scan, will get the diagnosis. And like I say, if the patient is in organ failure or if the disease burden is high, then a lot of time, many clinicians or many doctors will actually advise for chemotherapy first, because that gives a more rapid resolution of symptoms. But otherwise, this is definitely something that you can discuss with the doctor, and if it's available and within the financial budget, I will call it, of the hospital, and they're able to provide, then this is something that, of course, it will be beneficial for a lot of women out there.
Thanks, Jennifer. I have one last question. I think we are running out of time, but I think this is something important. We are talking all about people who have symptoms. Someone asked, how can I prevent breast cancer? What can I do to reduce the risk of breast cancer? I think I'll kickstart the answer. So when we talk about cancer as a whole, what we have learned from previous studies and looking at past people from elsewhere is that up to 50% of cancers are preventable. But when we look at breast cancer, the preventability is slightly lower than other cancers. But having said that, obesity or being overweight is one of the biggest issue, one of the biggest risk factor for breast cancer, especially women when they're postmenopausal. Likewise, alcohol intake is also another modifiable. We call that modifiable because we are able to do something about it and prevent. So I think these two are the most important things that you have to bear in mind. Having a healthy body weight, especially when you're postmenopausal, excessive body weight and excessive gain in weight puts a person at higher risk of breast cancer. And Aisha, would you like to add something?
Yeah, I think the general rule that we use to educate patients is from the World Cancer Research Fund. They actually have a lot of recommendation what you can do to improve your risk of having cancer. So I think you mentioned about obesity. They even put in things like physical activity. So you must be active physically, exercise at least 30 minutes every day, 5 days a week, right? And then you have to even cut down on sugary foods and drinks. So sugar is not exactly the best thing made for humans. So that is actually a very clear recommendation to cut down sugary drinks and food. Smoking, of course, even though not well proven for breast cancer, it can actually prevent other diseases and lung cancer, right? And then you have things like do not use supplements to prevent cancer. So that's actually from evidence-based material that is collated from around the world. So a lot of Malaysians, they like to use supplements and they use it to prevent cancer. So a lot of studies do not support that supplements can prevent cancer, because unfortunately, cancer is almost like a random event, isn't it, Prof. Nirmala? Because as you age, you're not able to, your immune system may be a bit impaired. Some mechanisms of the body, there are many mechanisms that will make cancer is impaired at that moment. So the best thing we can do is to be aware of the symptoms, any changes in your body, any lumps in the breast. And somebody asked, how does a breast lump feel? So we are collaborating with the Know Your Lemons Foundation in bringing the literacy materials to the community. It feels like a lemon seed. It's hard. And then if you feel it, if you cut across a lemon and then you try to move the lump, you cannot really move it. So it's an immovable hard lump. But again, breast lump is not just a symptom. So there are other symptoms that you need to be aware of. Please go to the website, Know Your Lemons, and you can find more symptoms that you can learn about to learn more about breast cancer.
I have actually put in the chat box, the WCRF guidelines of
great.
cancer research. So that's they provide a brief overview of how to prevent not only breast cancer, common things that can be done. And of course, Know Your Lemons is for breast cancer awareness. So that is something that you all can also visit. I think we are about over time. So
I suppose, can I just quickly throw in, when it comes to the risk of breast cancer, I think it's so important for us to just add on the genetic factor. So these are the non-modifiable risk factor. So if someone has got a strong family history, again, like first degree relative, like a mom or a sister that has got breast or ovarian cancer, especially at a younger age group, like when they are diagnosed, they are less than 50 years old, then please do consider seeking genetic counseling yourself, because then the genetic counselor will be able to map out your family trees, the family history, and decide what kind of test that is suitable. So if you are known to be a genetic mutation carrier, for example, if you are a BRCA1 or 2 carrier, then the risk of developing breast cancer is significantly higher. And so what do you do with that information is that you can actually do your screening much earlier. Instead, starting at 50 years old, then you shift that screening to like 10 years earlier. And what happened is that when you screen earlier, then the chances of detecting the cancer at the early stage, either precancerous or stage 1, becomes significantly higher. Then we know that if we detect the cancer at an early stage, then the survival increases dramatically.
Thank you so much. We missed that bit, so it's so important.
Maybe I should, sorry Nirmala, maybe a little bit, because a lot of people are having a lot of this consumer-directed genetic tests that you see on Facebook, right? Do not go for those tests. See a genetic counselor or a doctor first to know that you are doing the right genetic test. There's too many tests done, just need to send your saliva somewhere in the world. But those tests may not be the right test to actually detect this type of risk. So please meet up with your doctors, your general doctors, and if you have family medicine specialist doctors, even better. Or if you can meet up with your breast surgeons, also even better. So you can learn more about your risk and what you can do about that risk and whether you need to have genetic testing. Okay?
Thanks for pointing it out. I think at the end of the day, one of the important key messages apart from all that we said is if you are doubtful, please seek information from a healthcare professional. And when we say healthcare professional, it can be your family doctor, it can be the clinic kesihatan doctor or the family medicine specialist, and of course your breast surgeons. And then that will usually be your first point of contact. And based on that, they will reroute you to your oncologist who will provide more information. And we also have all these patient support groups and other formal sources of help. So with that, we hope that you can brave through the experience and come out as a winner, right? So with that, I think we are at the end of the session. It's 14 minutes past 9. Any last remarks that maybe I'll start with Mahis because I didn't get to say something. Mahis, you want to say any parting message that you would like to give?
I think from my side, I think in a lot of cancer awareness, I think there should be more information put in apart from the cancer sign and symptom only. I think there should be more information saying that cancer now can be cured. And there's more things that people has to look into the cancer awareness program that is actually happening. And most of the cancer awareness that currently is being done is mostly in the city and is not reaching many people. So those people who are there doing the cancer awareness, please make sure that you have a different type of messages for people apart from just the awareness on the sign and symptom, but tell them that, you can survive from cancer. And there's a lot of evidence now on that. So yeah, that's from me. Thank you.
Thanks, Mahesh. Jennifer, any
First of all, I'd like to thank the audience for listening in, and also to all the women out there, Happy Women's Day. So I think it's so important as women, from speaking from a woman to a woman, you want the woman to be empowered so that they should be at the core of the decision making. A lot of time, the decision is also fall back onto the family members to decide on what treatment they should have. But if the woman were to participate actively to deciding what treatment is suitable, so like, what Mahesh said, ask them what they want. So if the woman participate actively, there's already a contributing factor to the treatment success. So when you're out there in the clinic, do try to take it in, have this discussion with your doctors. Pick a doctor that you feel are suitable for you, that listened, and voice out all your fears when it comes to the treatment. Do not be afraid, especially on chemotherapies. And also there are a lot of other options out there. So, and also as a family member, be very supportive of what your wife or your sister or your mom is going through. And I wish everyone all the best in their treatment journey.
Thanks, Jennifer. Aisha?
Yeah, I think Mahesh, I try to answer your question about the cancer awareness. So we are doing this project called Rebom, Reducing Barriers in Urban B40 Group. We are producing awareness materials for the 4 cancers: breast cancer, lung cancer, cervical cancer, and colorectal cancer. And as you said, rightfully so, we need to improve the messaging, the hopefulness, and also navigation information. So we will be piloting in Taman Medan, Petaling Jaya. Hopefully that materials will be on YouTube, so it can be shared to everybody anywhere you are in Malaysia. So I think that project hopes to bring 17 stakeholders together and see how we can help to support communities through their community leaders with empowerment, with knowledge on cancer, and networking with cancer NGOs. So hopefully, Nirmala, we're all very hopeful tonight, and happy International Women's Day to everyone. And being women, I think we are stronger than we feel. So hopefully,
Thanks.
Okay.
And I would like to close the session. The only message that I would like to say is, apart from all the things that we said, when I said men must be in this together in order to achieve gender equality, it goes right from the time when a woman feels that something is not right with her body, or even if she wants to find out whether she might have any disease. At that point of time itself, her man in life, it can be the son, it can be the father, it can be the husband, it can be anyone, the boyfriend too, needs to stay with her. And it's not only throughout the cancer treatment, because long after she still needs the support. So stay with your woman, and happy women make happy lives. So with that, thank you very much.
Thank you for listening.
Thank you.
Bye.
Thank you. That's all the time we have for today's session. What an insightful session. So thank you once again to our speakers, Dr. Jennifer, Prof. Aisha, Mahesh, and Prof. Nirmala for moderating the session. For our audience, thank you for joining us. We hope we were able to answer most of your questions, to clarify your concerns surrounding this important topic. Before we end, please help us complete a short evaluation poll, which will pop up on your screen right now. Once again, thank you everyone for joining us. A big thank you to our official partner, Zuellig Pharma. Happy International Women's Day to our audience. Thank you, stay safe, and have a good night.